In this second portion of the large intestinal lectures, I'm going to continue talking about the normal appearance of the colon and the abnormal appearance that you will see in various disease processes. So again, it's a continuation of kind of what we've been doing before. I'm going to move to opacity and first think about the intraluminal contents, and those are going to be really variable. Fecal material is usually pretty heterogeneous. It's going to be a mix of soft tissue and gas, and there may be some denser stuff as well, so mineral opacity material, which could be mineral material that the patient has eaten, like bones, but it may just indicate that the fecal material is more desiccated and dehydrated than if it were more of a soft tissue opacity. And as you get that denser looking or more opaque intraluminal material in the colon, you have to differentiate that from what could potentially be small intestinal foreign material, so it can be a challenge. Foreign bodies can certainly make their way into the colon and are often of no consequence because once they've made it through the small intestine, they're unlikely to cause a large intestinal obstruction, although it can happen. And then you will see gas in the colon, sometimes a little, sometimes a lot. So here we have a cat, we've seen it before, has a redundant colon, and you can see normal fecal material here in the more proximal half of the colon, ascending, transverse, proximal, descending, and then gas in the more distal half of the colon, and this is all very normal looking colon. The size of the colon is variable, just like the rest of the GI tract, because it will dilate with fecal material or with gas as a normal part of daily life. And so the diameter of the colon in any given patient can vary, but it should be relatively constant for a given patient at a given time point. We don't see peristalsis the way we do in the small intestine. There are mixing movements or haustrations. There are mass movements, but it's not peristalsis in exactly the same way that we'll see in the esophagus or the stomach or the small intestine. Because of those movements, you will sometimes see folds or mildly narrower areas here and there as a normal finding. If there's a possibility that the colon is big, you have to decide if that might be normal for this patient under the circumstances, or if it's constipated, or if it may even represent a megacolon or pathologic enlargement of the colon. As far as diagnosing a megacolon, we do have some measurements that are used, although their utility is variable, or at least maybe somewhat limited. In a dog, you want to look at the colon diameter, and that should normally, from serosa to serosa, be less than the length of the L7 vertebral body. In a cat, look at the colonic diameter, and it should be less than 1.3 times the length of L5. If it's greater than 1.5 times that length, it suggests a true megacolon, obviously leaving us with a little bit of gray zone in between there. A megacolon, so generalized distension of the colon, represents just a diffuse dilatation and poor motility of the colon. And that can be either mechanical or functional. So it could be due to some sort of obstructing agent, whether that's a mass or a stricture, or it could be some underlying functional problem, some neurologic disease, for example, that allows it or fails to allow it to move the fecal material as it should. So as you can see on the second large bullet point, there are a lot of possible etiologies. Again, this can be a functional thing secondary to chronic constipation, so the fecal material gets dehydrated, the colon can't move it, and it continues to build up. It can be obstructive, it can be idiopathic. We see that in cats sometimes as an idiopathic disease. And then, like I said, neurologic and neuromuscular diseases and metabolic problems. So think about renal disease causing dehydration. Think about hypokalemia as causing decreased motility. Here we have a cat who's unsuccessfully straining to defecate, and I think it becomes fairly obvious what the issue is here, at least at some level, maybe not the underlying disease, but there's a lot of fecal material in this colon. It is massively distended with very dense fecal material. This fecal material is basically mineral opacity, so it's very desiccated. The cat is constipated, and one could say obstipated because it's much larger. The cat is going to have a megacolon. If you measure that versus whatever vertebral body you want, that's going to be enlarged. So this is a cat with a megacolon. Here it is on the VD view, same sort of look, lots of fecal material causing massive distension of that colon. We always want to look for some sort of cause for that disease. Is there some anatomic problem? Was there a pelvic fracture that has resulted in narrowing of the pelvic canal? Is there a mass here? A lot of times we don't see that on survey radiographs, but you still always want to look for it because there's a chance that you might see an answer here. In this case, I don't. When the entire organ is narrowed, or at least some portion of the colon is narrowed, whether it's focal or regional or diffuse, I think of a mass as causing it, or spasm, or strictures, and occasionally an extramural mass like we saw with lymph nodes compressing the colon. If there's actually an obstruction, a mass or stricture or what have you causing an obstruction, and so there's a focal area of narrowing, everything proximal to that or ORAD to that should be dilated because it's backing up as obstructions do. If you want to be sure that a narrowing is clinically significant, you do want to make sure that it persists and that we haven't caught one of these hostrations just at a coincidental moment in time, that there is a narrow spot over the span of 2 or more radiographs. And when you see that on survey radiographs, that would be a good indication for going ahead and doing a positive contrast or possibly negative contrast study to confirm that there is truly a narrowing there, whether that's a mass or a stricture, to explain the failure to defecate. So in this cat, we had such problems, and we did fluoroscopic evaluation of a positive contrast colonogram or barium enema, and so you'll see that the color scale is reversed relative to normal radiographs. So here the contrast medium is black and air is white. And the first thing we saw in this one image was that there is a narrowing of the colon, the very distal descending colon here, just cranial to the pelvis. And on the basis of one radiograph, we could be concerned that that might be a stricture, that focal narrowing, circumferential narrowing, but if it's transient, it might be a spasm. Neoplasia would also be on the list, but it's so focal, doesn't have a broad base to it, so I would put cancer as a lower likelihood. But again, we need to work out if this is something transient or if it sticks around, so you want to repeat that at some period of time. And what we saw was that the spot, now again circled in yellow, where the narrowing was before, now is normal. So that spot just cranial to the pelvis is now normal. So that was really just normal contraction of the colon, maybe spasm, but not a stricture. Now I see narrowing further down, further caudally, but again, that wasn't there before because it looked completely normal on the previous radiographs. So all of these are just indications of spasm, and they're not representative of true mural lesions. So let's go to another cat. Same kind of story, difficulty defecating, starting with survey radiographs. Pretty dramatic. Again, we've got a lot of fecal material in the colon here. So you get the old hashtag poop emoji going. And this cat is constipated, obstipated, if you want to say it's severe enough to be that point. It's distended, so I think that's fair. You can do measurements, probably going to measure as a megacolon, but I don't see a reason for that. And so that's something we want to work up further. Is there a mechanical issue here? Is it a functional issue? So we want to look and try to rule out some sort of mechanical problem. And we did a barium enema, again, lower GI series or a positive contrast colonogram. And we made a little bit of a mess of it, as can happen. So there's a lot of material, barium in the fur here that is leaked out. But we got enough of a study. We got good distension of enough of the colon to give us some answers. And what we see is that there's dramatic narrowing here of the kind of colon, really the most proximal portion of the rectum. And that's a pretty good explanation for why this cat is having a hard time defecating. Again, you can see this isn't something where we just didn't get good filling of the colon and rectum, because it's nicely distended caudally, it's nicely distended cranial to this lesion, and it just does not distend at that level. So the lumen's too narrow, the cat can't defecate, this is a stricture. We have a nice view of it on this oblique ventrodorsal view as well. It looks even worse, so severe narrowing, and that's the cause of our problems. Again, just a couple more views. Very, very little contrast medium in the lumen at that point, so this is a rectal stricture. We'll move to a dog. Again, start with survey radiographs, because we always want to start with survey radiographs to get our baseline. Maybe we see the problem. Here, there's a suspicion. There's what I can identify as fecal material in the descending colon, the more proximal portion of the descending colon. And then as I get to the distal part of the descending colon, we have this soft tissue opacity, relatively homogeneous structure that looks like it's causing dramatic narrowing of the lumen at that level. Now, maybe this is a foreign object, maybe it's some other problem. Could this be weird fecal material that just looks different from the rest? I doubt it, but maybe. It's certainly something that I'm concerned about, but we probably need to follow up on that. And we did. We added some air to the colon, not a high volume of air, so it's a low volume pneumocolonogram. But if I go back and forth, you can see that we did manage to distend the colon some, but we did not distend the lumen at all in the area of this soft tissue structure. We probably highlighted the margins of that mass a little bit better, but it stayed. So this is a real mass. This isn't just fecal material or something else. There's a circumferential soft tissue mass here causing dramatic narrowing of that lumen. And if we go to the VD views, survey on the left, pneumocolonogram on the right, we can kind of see the same story. It's a little bit hidden under the spine there, but we do get gas in the colon, and you can see that there's this soft tissue opacity structure that still sits there sneaking out from under the spine. So that is quite suggestive of the mass. Maybe an oblique view helps. There you go. Now again, we see that we have this circumferential mass and very little lumen running through that, so that's why this patient is having his clinical signs. We have differentials from cancer to granuloma. Realistically, cancer is probably more likely, and this ended up being a colonic adenocarcinoma. As with every other part of the GI tract, measuring the wall thickness is not fruitful. Most of the time on survey radiographs. The silhouette effect comes into play, so any fluid or soft tissue opacity fecal material is going to silhouette with the wall, and you're not going to know how much of that soft tissue opacity represents wall and how much represents intraluminal contents. So if you really want to know the thickness of the wall, then you need to do a contrast procedure. Again, either negative or positive contrast may help you out there, or you could do an abdominal ultrasound potentially to look at wall thickness as well. If the wall is thick, your differential diagnosis list is going to look similar to what it would look like for the small intestine. Inflammation, neoplasia, the thicker it is, the more likely it is to be neoplastic. The more irregular it is, the more likely it is to be neoplastic. So a dog with a barium enema, again, we're going to just jump right to it here. Survey radiographs are probably fairly unremarkable. And again, we got good distension of parts of the colon and rectum, mostly colon at this level, but there's an area that has a much narrower lumen, much less filling, and some irregular margins that you can see. So this is a very abnormal area, given the fact that it's a longer span, especially as we see on that VD view on the right side of the screen. Much more likely to be a mass than just a spasm. It's got a broad base to it. So some sort of mass, again, whether we're talking about cancer or granulomatous disease, cancer's usually more likely, and again, this ended up being a colonic adenocarcinoma. So with that, we've rolled to the end of part 2. Part 3, we will finish up the normals and abnormals of the colon, radiographically speaking.